We can start. So good morning and warm welcome to one and all to the online anesthesia postgraduate teaching program on Zoom platform, sponsored by Acrola and hosted by Logics. Today we have two interesting topics. The first topic is interpretation of ECG by Dr. SARVA VINOTHINI. Her lectures are very famous among the postgraduates. And the second topic is interpretation of X-ray chest by Professor S.Parthasarathhy. He is a legendary postgraduate teacher. He has agreed to take series of classes in forthcoming online anesthesia from next month onwards. With a small introduction, I hand over the session to today's session coordinator, Dr. Shanthini, madam. Thank you. Over to Shanthini, madam.
Today, I introduce Dr. SARVA VINOTHINI, ma'am. She is working as a consultant anesthesiologist in MIOT International Hospital. She is going to talk on interpretation of ECG. This is a very important topic. Please pay full attention because it's very important for our Viva session. So it's rarely discussed as a separate session during our the UG or PG period. So I welcome Dr. SARVA VINOTHINI, ma'am. Over to you, ma'am.
Good morning, everyone. Today's session is regarding the interpretation of the ECG, the basics. This session is designed to aid the exam-going PGs who might have the ECGs given in their OSCEs or in their Viva OC. So, and few tips and tricks regarding the interpretation of ECG. We all know regarding the conduction system of the heart, which begins in the SA node and ends in the Purkinje fiber. Not just each cell in the conduction system, in fact, each myocardial cell has an intrinsic atomicity. Because SA node fires at a rapid rate, SA node is the dominant pacemaker of the heart. The cardiac cycle is in close relation with the ECG. The P wave represents the atrial depolarization, the PR interval represents the AV nodal delay, and the QRS complex represents the ventricular depolarization, and the T wave represents the ventricular repolarization. The 12 leads act as the 12 cameras in the ECG. The 6 limb leads view the heart in the sagittal plane, and the 6 chest leads view the heart in the coronal plane. Hence, we have a 360-degree view of the heart, and each lead in an ECG depicts specific regions. 2, 3 AVF depict the inferior region of the heart, and 1 and AVL depict the high lateral region of the heart. V1 and V2 depict the septum, V3 and V4 the anterior wall, and V5 and V6 the lateral wall. The mean electrical axis of the heart is the summation of numerous vectors in the heart, and the mean axis is between 0 to 90 degrees. So when the wave of depolarization occurs in this direction, and when there are numerous measuring electrodes, so if the electrode is here, and if the wave of depolarization goes on towards this electrode, then this electrode records a positive deflection in the ECG. And if the wave of depolarization is going to go away from an electrode, it records a negative deflection in the ECG. And if the wave of depolarization traverses along these electrodes, we get a biphasic waveform in the ECG. Thus, we have different morphology in different leads. Because the QRS complex is always, the mean electrical axis is always away from the measuring AVR electrode, all the waves in AVR are usually negative. It is only in dextrocardia where the waves in AVR will be positive. So this can also be a guide for the proper placement of the ECG. So we should know to interpret our ECG paper also before knowing to interpret the ECG. So each small square in the ECG paper represents 0.04 seconds, and each large square represents 0.2 2 seconds. The ECG is usually swept in a speed of 25 millimeters per second, and the standardization is 10 millimeters representing 1 millivolt. 2 large squares represent 1 millivolt. So always look for the standardization and the standard sweep speed on the ECG. The 7 steps that are used to determine the ECG are the rate and the rhythm, which go hand in hand, followed by the P wave, PR interval, QRS complex, ST, and others. So how do you determine the rate in ECG? The rate is determined by determining the number of large boxes or number of small squares that are present between 2 QRS complex. So if you're going to use large boxes, it's going to be 300 divided by the number of large boxes, or 1500 divided by the number of small boxes between two QRS complex. So if there are 4 large boxes, the rate is going to be 300 divided by 4, that is 75. If it's going to be 2 large boxes, the rate is going to be 150 per minute. Then coming on to the rhythm, as we saw earlier, the rate and the rhythm go hand in hand. So we have to determine first the rhythm is regular or not. We'll have to see if each P wave is being followed by the QRS complex and if the RR intervals are constant. In that case, we can use our previous formula, 300 divided by the number of large boxes between 2 QRS complex, and we get their heart rate. What if the RR intervals are not constant? In that case, we'll have to determine the number of QRS complexes that are present in 30 large boxes, which amounts to 6 seconds, and multiply that by 10 to get a mean heart rate. So having known the rate and the rhythm, we're just going to focus on the rate and the rhythm in the following ECGs. So what about the rhythm? The RR interval occurs constant and each P wave is being followed by the QRS complex. So the rhythm is regular. And what about the rate? There are 3.5 large boxes. So it's going to be 300 divided by 3.5. The rate is 85 per minute and the rhythm is regular. So this is a normal ECG. Coming on to the next ECG, we're just going to focus on the rate and the rhythm. The RR interval occurs at a constant intervals, and each P is being followed by the QRS complex. And what about the rate? There are 6 large boxes, so it's going to be 300 divided by 6. The rate is 50 and the rhythm is regular. So this is sinus bradycardia. Again, just focus on the rate and the rhythm. What do we see here? Each P wave is being followed by the QRS complex. And what about the RR intervals? We can see that the RR intervals are wide here and they are narrow here. So the RR intervals are varying. So it is irregular. But if we carefully observe, we can see there is some regularity in this irregularity also. So it is wider RR interval followed by narrow RR interval and again wider RR interval. So if this has got a relation with respiration, then we can brand this as sinus arrhythmia. Sinus arrhythmia is common in asymptomatic young males, usually who have vagal predominance. So there is a variation that occurs in the heart rate in relation to respiration. So during inspiration, the heart rate increases, and during expiration, the heart rate decreases. So this is called a sinus arrhythmia. So having seen the rate and the rhythm, now we're going to look at the P wave. So when you're going to look at the P wave, you'll have to remember this. Always look for P wave in lead 2 and always remember 2.5 into 2.5. So a P wave usually occupies a height of 2.5 millimeter and usually occupies a width of around 2.5 small squares. So always remember this. And the P wave is because of the atrial depolarization. So the first half is represented by the right atrial depolarization and the second half by the left atrial depolarization. So what happens if there is a right atrial enlargement? Then the first half of the wave is affected and hence the amplitude increases and the P wave height will become more than 2.5 millimeter and we get to have a tall or peaked P wave that is called as a P pulmonale, which is pathognomonic and it is characteristic of a right atrial enlargement. What happens if the left atrium is enlarged? Then the second half of the P wave will be affected. So we tend to have a broader P wave or a wide P wave and a bifid or a notched P wave. This is indicative of left atrial enlargement. This is also called as P mitral. This is commonly seen in mitral stenosis. Apart from this, we can have an inverted P wave, a polymorphic P wave, or flutter waves, fibrillatory waves, or an absent P wave. So we're going to concentrate on the rate, the rhythm, and the P wave now. So what about the rate? The rate is very high here. And what about the rhythm? The RR intervals are not constant. We don't see constant RR intervals here. So it is an irregular rhythm. And what about the P waves? We do see P waves before each QRS complex, but we can see the P waves are actually different. We see many different kinds of P waves here. So the P waves are actually polymorphic, and this is called as polymorphic atrial tachycardia or multifocal atrial tachycardia, which is common in patients with lung symptoms like COPD and increased sputum production, etc. So what is multifocal atrial tachycardia? Here, different sites in the atria generate impulse at different points of time. So depending upon where the impulse originates, the morphology of the P wave varies accordingly. So to brand this as a multifocal atrial tachycardia, we should be able to demonstrate at least 3 different types of P waves in a patient with tachycardia. So this is common in patients with lung diseases. And what do we see here? Again, the rate seems to be more, but the rhythm seems to be regular. And what about the P waves? We don't find any P waves, but this is not atrial fibrillation because we don't find any P waves, because the rhythm is regular. So you have a regular rhythm with an absent P wave. Actually, the P waves are buried under this later part of the QRS complex or the P waves. So this is supraventricular tachycardia. Here the QRS complexes are occurring at regular intervals. And what about the P waves? We don't see any isoelectric line at all. All that we see here are like picket fins or sawtooth appearance, and all these are P waves. But the QRS complexes are occurring at a regular intervals. This picket fins or sawtooth pattern is characteristic of atrial flutter, and because here this patient has a fixed AV block. So for every 3 P wave, 1 QRS complex is generated. So because the AV block is fixed, we tend to have a regular rhythm. So this is an atrial flutter with 3:1 AV block. So for the atrial rate is 216, the ventricular rate is 72. So for every 3 P waves, you get 1 QRS complex. So this is an atrial flutter with a fixed AV block. This is also atrial flutter. We have a similar sort of the picket fence pattern, but we can see here that the RR interval is varying compared to this where the RR interval was same. We have a varying RR interval here. So this rhythm is irregular because the AV block is variable. So this is an atrial flutter with a variable AV block. What is atrial flutter? In atrial flutter, we do have an ectopic site in the atria which keeps firing at around 250 to 350 times per minute. So depending upon how the AV block is, whether it's fixed or varying, we tend to have a regular or an irregular rhythm. What do we find here? Here, the rhythm is irregular. The RR intervals are occurring at, the RR intervals are not constant. It is varying. So we have an irregular rhythm. And what about the P waves? We don't find any distinct P waves. Instead, we find a fibrillating baseline. So this is indicative of atrial fibrillation. What happens here? Multiple sites in the atria fire at larger 350 times per minute, and the atria just fibrillates. So there's no proper contraction of the atria to generate a P wave. So the atria just fibrillates, and we tend to have a fibrillating baseline or an absent P wave. Having seen the rate, rhythm, and the P wave, next is going to be the PR interval. The PR interval occurs because of the intrinsic delay in the conduction of the impulse in the AV node. This is essential for the atria to completely empty the blood into the ventricle and for the ventricle to be completely filled before it begins to contract. So this intrinsic delay is normal. So what all can happen in the PR interval? This can become short when there is any accessory pathway like WPW syndrome or Long-Ganong-Levin syndrome, or it can be prolonged or it can be variable. So now we have to concentrate on the rate, rhythm, P wave, and the PR interval. So what about the rate? It seems to be like tachycardia. Rhythm, there's a P followed by QRS complex, and the PR intervals are occurring at regular intervals. So the rhythm is regular. And what about the PR interval? The PR interval is very short. And we can see a slurring QRS complex that is occurring. So this is pathognomonic of WPW syndrome. What happens in WPW syndrome? When an impulse is normally conducted in AV node, there is a delay in AV node which gives rise to this PR interval. But what happens here? The impulse starts, though the impulse is delayed here in AV node, the impulse takes this accessory pathway and it gets transmitted to the ventricles. So the PR interval is actually shortened, and because the ventricles are being depolarized via this accessory pathway, you have a slurring upstroke of this QRS complex. So the triad of WPW syndrome can be remembered using WPW itself: a delta wave, shorter PR interval, and a wider QRS complex. If there is any re-entry that is happening via this accessory pathway, depending upon the direction of the re-entry circuit, you can have an QRS complex as an orthodromic or antidromic conduction. To sum up, all the tachycardias of atrial origin will have a narrow QRS complex, except for WPW syndrome, which doesn't have a wide QRS complex. It just has a slurring upstroke of the QRS complex. So always remember, all the tachycardias of atrial origin will have a narrow QRS complex, and the rhythm can be regular or irregular depending upon the kind of the arrhythmia and depending upon the kind of the AV block that is present. So what do we see here? So we see here that the RR intervals are occurring at constant, at regular intervals. So the rhythm is regular, and we do have a P wave. But what we find here is the PR interval is prolonged. The PR interval should usually be around 0.12 to 0.2 seconds. So it should usually occupy only one large box. So we see here that the PR interval is prolonged in each of the beats, and it is constant. So this is a first degree AV block. In first degree AV block, the intrinsic AV nodal delay, which is physiological, becomes pathological. So that there's a further increase in the delay. So the PR interval is prolonged and it is constant throughout each beat. So that is the first degree AV block, which is a fixed PR prolongation. What happens here, this patient is a 55-year-old patient who's posted for TERP, and this is ECG. What we can see here is, we do see the RR intervals being regularly irregular. And what about the P waves? So we can see there is a pre-IPR prolongation. The next P wave is even more prolonged, and then you have a P wave which is not followed by QRS complex, and the cycle continues. So you have a wider PR interval, even wider PR interval, and you have a dropped beat. So this is Mobitz type 1 or second degree AV block type 1, also called as a Wenke-Bach phenomenon. How do we remember this? We can remember this as sequential widening of the PR leading on to one drop beat. So second degree AV block, Wenke-Bach phenomenon, Mobitz type 1. So sequential widening of the PR eventually leading on to one drop beat. So it conducts with delay, it conducts with even more delay, and eventually fails to conduct and leads to a dropped beat. It's a 40-year-old male with occasional episodes of fainting. So what we can find here, the rhythm is irregular, and we have P wave followed by QRS complex, but then we have P waves which are not followed by QRS complex also. So this is a second degree AV block type 2, wherein you have the P waves, the PR interval, P wave is the normal PR interval, and the P waves which are not followed by QRS complex. So in type 2, you have two different types of P waves. One P wave which is normally conducted, hence has got a normal PR interval, and the other kind of P wave which is not followed by QRS complex, and hence is a dropped beat. So you have two types of P waves. This patient is an 80-year-old patient who has broken her hip, and the surgeon wants to operate this patient. So what is our comment here? What do we see here? We see here that the RR interval, we see some bradycardia here, and the RR interval is fairly okay. But what about the P waves? We see numerous P waves when compared to the R waves. Okay, so there is total discordance between the P and the QRS. So this is indicative of complete or third degree heart block. So we shouldn't take this patient up for surgery now. This patient requires temporary or at least permanent or at least a temporary pacing immediately. So what happens in complete heart block? The impulses from the atria are completely blocked. They are not going to the ventricles at all. And then how does the QRS originate? It originates because of an escape rhythm that depending upon where the escape rhythm originates, the QRS complex can be narrow or wide. Does these AV block teach us life lesson? If we consider this as a normal rhythm of life, the P and the QRS is the wife and the husband, and the PR interval is a relationship between them. The first degree AV block represents a strain in their relationship where the distance between the P and the QRS increases. So that way the PR interval increases and it is constant. So still they are in that relationship. What happens in second degree AV block? The PR interval progressively increases and eventually there is a drop beat. So eventually the QRS goes out of the circle. In the second degree AV block type 2, whenever there is a P, though the PR interval seems to be normal, there are frequent dropped beats because the QRS has gone out of the circle. Here the QRS was just in the circle. So the PR interval is progressively increasing, then a dropped beat, then again the cycle continues. But here the number of P waves will be more than the number of QRS complexes, and the PR interval will be normal, or the P wave will be a dropped beat. Here there is total discordance between the P and the QRS complex. So having seen till the PR interval, now we're going to see the QRS complex. The QRS complex represents the ventricular depolarization. It is usually represented by 3 small squares and less than 120 milliseconds in duration. The QRS complex is the primary determinant of the cardiac axis. What are the problems that can occur? You can have a wide QRS complex or a tall QRS complex. Always remember, in a tachycardia, if the QRS complex is narrow, then the origin of tachycardia is above the ventricle. If the origin of tachycardia is in the ventricle, then definitely you have a wide QRS complex. The other reason for the wide QRS complex is bundle branch block, and the QRS can be tall when there's ventricular hypertrophy. So what do we see here? Our concentration is going to be on the QRS complex. We see that the rate is more and the rhythm seems to be regular. We don't find any P waves, so no PR interval also, and the QRS complexes are wide. It is more than 3 small squares. So this is ventricular tachycardia. This is also a kind of ventricular tachycardia, but the difference here is we have varying amplitude and varying axis of the QRS complexes. So this can be, with the outline of these things will resemble the outline of a party streamer. So this is called as Torsade deep pointers. This occurs in patients with long QT syndrome or when there is any R1T phenomenon. So this is the difference. In monomorphic ventricular tachycardia, all the complexes are wide, but they appear similar. But in Torsade deep points, we can see that there's a varying amplitude and varying axis of the QRS complex. This is common in patients with channelopathy, and there is R1T phenomenon. So what do we find here? We cannot actually make out any distinct waves at all. So this is ventricular fibrillation. This is an emergency. The patient has to be defibrillated. How is a QRS complex actually formed? The initial depolarization forms the first stage of the QRS complex, and the initial depolarization occurs first in the septum. It occurs from the left to the right. So it records as a positive deflection in V1 and a negative deflection in V6. Then, because the left ventricle has more muscle, the left ventricle has more influence. So the right and the left bundle branches transmit the depolarization current, but because the left ventricle has more muscle, that has more influence. So we see the recording as a predominant negative deflection in V1 and predominant positive deflection in V6, and ultimately it returns to the baseline. So we can see a gradual progression of the R wave from V1 to V6, and the transition point, that is where it is biphasic, is usually between V3 and V4. So this is the normal progression of the R wave. If there is right ventricular hypertrophy, there will be poor progression of the R wave, and the transition point will be somewhere around V5 or V6. So the small q in V5 and V6 is physiological. When do we term it as pathological? We term it as pathological when the duration occupied by the q is more than 3 small squares, or when the height is more than 1/3 of the QRS complex. So as we saw, this is how the normal QRS complex is generated. When there is a right bundle branch block, what happens? Because the septal depolarization occurs from left to right, that is not affected. So the first part of the wave is not affected. And because left ventricle mass constitutes the major portion of the QRS complex, and the second wave is also predominantly because of the left ventricular depolarization, so that is also not affected. The first and second part is not affected. But because the right bundle branch is blocked, the right part of the ventricle has now to be depolarized via the myocardial cells, so not via the conduction system. So it is going to take longer time, and hence we tend to have another R prime in the V1 or a broader S wave in V6. If it is difficult for you to remember this, we can remember this as M in V1 and W in V6. That is significant of your right bundle branch block. What happens in left bundle branch block? If there is left bundle branch block, the first part itself will not happen because the septal depolarization has to happen from the left to the right. So that itself is not going to happen. So you're not going to have the first initial R wave or the initial Q wave in V1 and V6. So what we're going to have is the second part that is going to be grossly prolonged. So you're going to have a wide and deep S wave and broad R wave, because the whole of the left ventricle mass has to be depolarized via the myocytes and not via the conduction system. So we tend to have W in V1 or an M in V6 that is significant of a left bundle branch block. So we are going to concentrate on the QRS here. What do we see here? We can see RSR pattern in V1 to V3 and a slurring in V6. So this is indicative of right bundle branch block. And here we can see the broad R wave or the M pattern in V5 and V6 and a sort of W pattern in V1 to V3 and in V3 and also. This is indicative of left bundle branch block. How do we determine the chamber hypertrophy? There are numerous criteria. It might be difficult for us to remember all the numbers when you're going for exam. So it can easily remember as if it's right ventricular hypertrophy, the R in the V1 should be more than 7. And the if it's left ventricular hypertrophy, the R in the V6 should be at least 4 times of this. So it should be at least 26 or 28 if you want to remember it easily. So if the R in V1 is more than 7 millimeter, it's right ventricular hypertrophy. The R in V5 or 6 is more than 26 millimeter, it's left ventricular hypertrophy. And we'll be having the reciprocal things of the S wave in the reciprocal leads. So we'll have a deep S wave in V5 and V6. We're going to have a deep S wave in V1 and V2 in patients with left ventricular hypertrophy. Other associated findings will be the appropriate axis deviations and the bundle branch block. And in addition, as we saw earlier, we'll have a poor R wave progression in RVH and a delayed intrinsic deflection in LVH. So the axis usually determined by taking lead 1 and AVF into account. This is your normal axis. This is left axis deviation. This is right axis deviation. So we usually take into consideration the lead 1 and AVF. You can use the thumb rule, or we can see the axis in the ECG itself. So we can remember this by usually the normal axis, both the QRS complex in lead 1 and AVF will be pointing up. So it will be predominantly pointing up. But what happens if there isn't right axis deviation? Both the QRS complexes will be reaching each other. So lead 1 and AVF will be reaching each other. And if it is left axis deviation, they'll be leaving away from each other. So right reaches and left leaves. So you can use this as a mnemonic for right axis deviation, left axis deviation. So what do we see here? We see here that the QRS complexes, both the QRS complexes are reaching each other. So this is right axis deviation. And here both the QRS complexes in lead 1 and AVF are moving away from each other. So they're leaving. So this is left axis deviation. So what do we see here? Here we can see tall R waves. And what about the axis, lead 1 and AVF? What happens here? They both are reaching each other, which is right axis deviation. So this is right ventricular hypertrophy. And what do we see here? Predominantly tall R waves in V5 and V6. And what about the axis? V1 and AVF, they are moving away from each other, leaving each other. So it is left ventricular hypertrophy. So having seen till the QRS, now we are going to see the ST. So ST segment elevation indicates myocardial ischemia. So we already saw the regions that are depicted in the ECG. So it not just depicts the regions, it in fact depicts the arteries supplying those regions also. So lead 2, 3 and AVF changes can occur when right coronary artery is involved. So in leads V1 to V4, there can be ST segment changes when left anterior descending artery is obstructed or occluded. The changes that can occur in the lateral leads when the diagonal branch of left anterior descending artery and the left circumflex artery is involved. So if left circumflex or diagonal branch is involved, we can see the changes in lead 1 AVL or V5 and V6 and 2, 3 AVF are pathognomonic of right coronary artery involvement. So what we can see here in the ST segment, we can see an ST segment elevation occurring in V2 to V5. This is actually called as storm-shaped elevation. It is this carries high mortality. So this is an anterolateral ischemia. We can see the reciprocal changes also happening in the inferior leads. We can see an ST elevation here occurring in leads 2, 3 and AVF. So this is an inferior wall myocardial ischemia. This is usually associated with bradycardia. Having seen till the ST, the last part will be to to evaluate the QT and the U waves. So what do we see here? Here we have a normal P wave, normal PR interval, the rhythm is regular, everything is fine, but the QT is prolonged. So how do we determine the QT interval? The QT interval has to be corrected to the heart rate. So that is called as the corrected QT interval. That is the Besset's formula. That is QT interval divided by the RR interval. So the QT interval here is around 0.6 seconds and the RR interval is around 1 second. So the QT interval is around 600 milliseconds. The normal QT interval is around 450 to 480 milliseconds in females and males. So here it is prolonged. This prolonged QT interval can lead to the torsade points or the polymorphic ventricular tachycardia. And what about the relation between serum potassium and ECG? A hypokalemia, because it is a lower level, you can remember as hypokalemia depressing the ST segment. The hypokalemia will depress the ST segment, will cause T wave inversion and a prominent U wave. The hyperkalemia, because it indicates a rise in potassium level, it will pinch the ST segment. So you tend to have, so hyperkalemia will depress the ST segment, this is going to pinch up the ST segment. So you tend to have tall, tented, peaked T waves. And that because of the pinching up, eventually you have a QRS prolongation, flattening of the P waves and PR prolongation, ultimately sine wave pattern can arise. So this is a 60-year-old on furosemide. What do we see here? We can see that there is an ST depression and a T wave inversion and a prominent U waves that can be seen. So this is indicative of hypokalemia. And this is a patient who missed his last session of dialysis. What we can see here is tall, peaked, tented T waves, so which is pathognomonic of hyperkalemia. If left untreated, this can lead on to the sine wave pattern and eventually ventricular fibrillation. So these are the 7 steps that we have to follow: the rate, the rhythm, the P wave.
Thank you, ma'am. That was a huge amount of information in a very short time. You have covered every important point in ECG. Thank you very much, ma'am. So there's no doubts in the chat box. Because of the short duration, we will go on with the next session, and the doubts will be answered in the chat box. So the next session is interpretation of the text by Dr. Parthasarathhy sir. Introducing Parthasarathhy sir means a separate session actually. So sir is an epitome of an avid learning and adept in teaching and Christian practice. He was a keen learner at school and continued the same during graduation at Tanjavur and PG at Business. In his best for out of doors, he has studied acupuncture, computer applications and statistics. He also holds DMD in anesthesia, PhD in physiology, diploma in diabetology, regional anesthesia and echocardiography. And at present, he is a professor of anesthesia at Mahatma Gandhi Medical College and Research Institute, Puducherry. He is well known for his teachings through his website, Pain Free Partha, and Fridays every week in Zoom. So we are eager to learn the interpretation of express from you, sir. Welcome, sir.
Whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, who is currently the director of e-learning in Mahatma Gandhi College. Now, whenever you start reading an X-ray, don't go straight. See whether it's the right patient, what we are seeing. Whether the patient is Gopal, Ramu or Shanthini. Is it the right position? Or is the overall the patient is fine? For example, the patient is sick like this with ICD. How is the patient? Just get to know all these things before going on to read this. AP or PA, confirm. Because just ask the sister, ask somebody else, we know that this is AP or PA, because this is a previous day AP, while this is a, you can see this is the previous day, same patient, next day PA. Now, the start interpretation, see here, left side, because people may be very particular in diagnosing the cardiac X-ray test, so beware, this is left side. Now, this is the medial end of the clavicle. Medial end of the clavicle is center, and the trachea and the vertebra is in the center. It is not rotated like this, then it means it is centrally placed. Medial end of the clavicle, yes, you can see this is what is called this position is found. Closer lung, everything wider. That is why we should do this. Now we can see this is the left rotation. The left lung looks little wider. You can see it's a left rotation. Now go to the, now we can see what is the patient, right? Which is the, we have checked the left or right, and which patient is AP or PA, and rotation is there or not there. When you go to the X-ray, if we check at the lower part of the cardiac shadows, spine should be just visible. No clear demarcation. Spine's not at all visible, means it is under protection. And see here, it is, nothing is seen here, something is seen here, and you can see nothing is seen. Or other, if we go to T4 level, there you can see very clearly the upper and lower part of the vertebra. Then it means the exposure is over. If you are not able to see the upper and lower part of the vertebra, then it is underexposed. Overall, we should see the X-ray. Here you can see if there is going to be a TB in the apex, it is missed. This X-ray is fine, but it is missed here. Now you can see there is no right CP angle. If there is a pleural effusion here, we might very well miss this. Right CP angle is not at all shown in the X-ray. Now I will go whether the X-ray is taken in inspiration or expiration. We want X-ray just in inspiration. Sixth rib is anterior. That is what is here. Should be seen. First anterior. This is anterior. This is posterior. Anterior 1, 2, 3, 4, 5, 6. So this is okay. This is taken in inspiration. And ninth rib is posterior. We noted. If it is not taken properly in deep inspiration, the heart may show little bigger and basal shadows may be there. So that is why here I am showing the anterior ribs. So this is the posterior ribs and this is the anterior ribs. So we have got patient name, site, position, exposure, rotation, inspiration or expiration. Now what are the things to start from soft tissue? Bones, mediastinum, angles, heart and vessels, and lungs. Go methodical, otherwise you'll miss many things. Now, for example, if you have not looked at exactly the lungs only, heart is damaged and all, you will clearly miss this beautiful emphysema here. You will miss, so go methodical, right from the soft tissue. Now you can see the bones, scapula. You can see the amount of fracture ribs is there. There are multiple fracture ribs. If you are not going methodical, the soft tissue, then bones, you are likely to miss fractures. See, bones among the scapula pato. Then we saw this ribs. Then see here the scoliosis is so much. If there is so much of scoliosis, we should interpret this first, because if there is so much of scoliosis, we may interpret this as disease, we may interpret this as disease and all. So just see the bones. Now after seeing the bones, we will come back. We will come to the costophrenic angles, the diaphragm. This is costophrenic and this is cardiophrenic. This cardiophrenic and costophrenic. See, this angle is not at all here. Highest point is the middle of the lung field, right. The right highest point is the middle of the highest point is this. Highest point is little lateral here on the left side. There should be a smooth contour. All these things should be seen, because if the diaphragm is not smooth, diagnosis is different. If there is a subdiaphragmatic air shadow, the diagnosis is different. So this is fine or not. Cardiophrenic and costophrenic angles should be seen. Diaphragm should be seen. Usually the left CP angle is little low. Now CT ratio is a 50%. If it is above, then it is cardiac. Now we have to be very clear in how to measure this. This is the maximum bulge on the left side. The maximum bulge length, you have to go to the midpoint of the vertebra. And then again, where's the maximum bulge on the heart here? Here it is there. So we have to make plus, this plus, and then there should be more than this, the half of this. Then it is called most cardiovascular. Cardiothoracic tissue is more than 50%. It is just not like this. It is like this plus this should be more than 50% of this. So here there is a mediastinum. There is a small fussiness here. Now we have got this, and we have got this. Then we go to the mediastinum, aorta. Then we get the pulmonary artery. This is, I am on the left side. This is the left atrium. Then we can see the left ventricle. So on the left side, it's an exam question. Aorta, pulmonary artery, LA, LV. That we should tell. In the right side, it is SVC plus RA. That is what we should tell in a normal X-ray. But many times, if you get the same picture for identification, prominent aortic knuckle. You can see here, prominent aortic knuckle. We can see here, this is a left atrium is not, this bay is not coming. Now we can see the left atrial bulge. Now this is somewhat some sort of pulmonary hypertension. There is a left atrial enlargement, and there is also the left ventricular enlargement. Now this here you can see the first one, SVC. Right atrium. SVC is also slightly prominent, and the right atrium is enlarged. If you want to see. Then now it is mediastinum over. Now we will go up to the trachea. Now the trachea is in the midline. No, it is shifted to the right. Before that, you see here, it's not correctly positioned. That is another thing. With the trachea, where is the mediastinum? Here it is pushed. Now we know rotation, exposure, soft tissue, bones, mediastinum, trachea, angles. Then we will go to the lung parenchyma. This is what is the time we should go to the lungs. It is not that immediately if we see pneumonia right side, pneumonia left side, pleural effusion left side, nothing like that. You should see it's a rotation, exposure, soft tissue, bones, mediastinum, trachea, angles. Now what I call is upper zone is not equal to upper lobe. Second costal cartilage to the axilla. The middle zone is second to 4, and the lower zone is below 4. Now you can see here. This is what is the upper zone, this is the middle zone, and this is the lower zone. Whenever you are commenting any disease here, we should tell it is in the lower zone and not in the lower lobe, because we don't know where is it. Sometimes this may be upper lobe also. So we should comment it is in the lower zone, middle zone, upper zone. Sometimes some discus got 3 lobes, this may not have 3 lobes. But zones are different. Reminder, all these things are anterior, not posterior. See here, anterior ribs, second and fourth, third and fourth. See here, this is the anterior rib. What is there in this? Whenever we explain this, we should tell whether it's an homogeneous or heterogeneous mass. Here you can see it's an homogeneous mass. A gap, white and black line. So homogeneous picture. Where is the sign? It is in the right lower zone. This angle, mediastinum is okay, trachea is okay. The angle is not very much completely abolished. There is something here. So it is less likely to be fluid. So it is possibly a lower lobe movement. Now you can see here the trachea is reclined, the mediastinum is completely pushed, and there are normal vasculature here is complete, no shadows. This is what is called a pneumothorax. Here also we can see a small pneumothorax here. There are no bronchovascular markings. This is what is very important whenever you determine a hyperechoic shadow with push of the mediastinum. Now you see, I have already told, fourth is the upper zone, mid zone, lower zone. Now this is in the upper zone. Upper zone, now we can see as a homogeneous shadow. A homogeneous shadow, the trachea is slightly pulled maybe the pull of the trachea may be collapse. The collapse of the possible collapse of the hormone. Now you see the trachea is pushed here, pulled like this. Mediastinum is irregular. Big cavity here, lot of infiltrates. Here also there is one cavity. Yes, it looks like an active tuberculosis. Here you can see this. It doesn't look like it. Here you can see the diaphragm is not very regular. The contour, so-called, this thing is not there. The contour is not bulged like this. All these things possibly, maybe here you can see this is what is a case of silicosis. Here you can see if you miss like this, you are obviously likely to miss their performance. So directly avoiding pneumothorax and things like this, directly seeing the lung shadows, yes, you are likely to miss their perforation. Here you can see flat, irregular diaphragm, complete emphysematous lungs. This is like slightly tubular heart. Now this is likely to be emphysema. Now this is, you can see here, a push, you may think that it is a collapse. Here you can see this is also lifted up. There is a conclusion. That is why we should always see the history and the patient overall, because this patient has had a history of surgery left front. So it's a case of pneumonectomy. Some lifelines can also be assessed. Central line, tracheostomy, nasogastric tubes, endotracheal tubes. See, this is the tracheal tube. Here you can see this lifelines coming like this. Again, you can see here central lines here. Nasogastric tube is here. Pacing wires. All these things can also be seen in X-ray test. What is this? Looks like normal. Or here there is nothing is seen. Is it exposed normally? Here you can see this clavicle is normal. Bones looks normal. Expiratory film. Yes. That is the problem in that case. Right-sided chest pain and cough. You can see a small gas shadow here. There is, see here, the bronchovascular markings are well seen. This bronchovascular markings are not well seen. Probably a right-sided pneumothorax. A cough with fever. Now we can see this is slightly shifted to the right. It may be okay, but it is normal. Mediastinum looks normal. Trachea is normal. All this is normal. But a heterogeneous shadow occupying the upper and middle zones, and there is no shift much of this. This is looking like a fever and a possible pneumonia. Now we can see there are two X-rays. This X-ray, we can see this mediastinum is completely shifted to the left. There is a big homogeneous shadow, completely, obviously obliterating the right chemithorax completely. So this is pushing. Push was complete obliteration, complete homogeneous white shadow, obliteration of the angles. It is likely to be an effusion. But here you can see complete white shadow. Even though it is there are some black here and there shadows. So there is a tracheal pull here. All mediastinum is likely full. It is likely to be pleural effusion, and the lower one is a collapse. Now we will go to some examples. So post-op laparoscopy case, we can see a small shadow here. The homogeneous shadow in the left upper. Here we can see this is possibly a minor fissure which is being pulled with fluid. Probably a third day, we are just getting all your IV fluid getting back to the lungs after a laparotomy, which is associated with the small lungs. I will go to salute site. There is a shadow. Now there is a shadow. Heart plainly or it is in a different plane. That is what is called solution. If it is going to be in the plane of the heart only, then this border is not very clear. This shadow a bit clearer if it is going to be demarcated, then it is called the silhouette sign. Then the cardiac shadow, whichever AP is there, if that mass, this swelling or this disease is not in that plane of the heart, that is what is called. Now we can see this is a complete again destroyed lungs, this destroyed diaphragm, not proper here. So it is likely to be emphysema. Smoker for years together, dry cough, wheezing. What is this? This patient has got a cough with expectoration, with clubbing. Okay, so this is everything is normal. This is normal. There is no push-pull. This is a very good inspiratory filling, and subcutaneous tissue is normal. These angles are normal. Okay, now you can see an heterogeneous shadow of the right and left lower zones, and both sides. Now you can see there is a clubbing. All these point out to abnormalities. So this X-ray is cut down to focus on something else. If you miss the bones, yes, you are likely to miss a cervical rib in this case. Then everything is fine, completely this is pushed up. Something wrong somewhere? Yes, this is completely gut is occupying. This is the invertation of the diaphragm. All your large gut is in the thorax. It looks like everything is fine. Here, normally repeated film, just here. Here the subcutaneous tissue, all these things are normal. There is a big cardiomegaly, homogeneous. It is likely to be a pericarditis. 5 days fatigue, loss of smell, mild fever. This is ground glass opacities on the peripheries, characteristics of COVID. Now what you can see here, this is not a very exposed film. Trachea is not well seen, but still we can see a homogeneous round mass. It is relatively regular in this, in the left upper zone. This we call as solitary pulmonary nodule. The primary aorta, maybe secondary also. That but now we can see again another. This is small. Unless we go methodical, here you can see this is not there. We cannot comment the CT angles, but we can see here a small cavity. Just we focus only after the reach into the lungs. Yes, we are clear. What is this? Big hilar mass. Here you can see the diaphragm is normal, trachea is normal, bones looks normal, subcutaneous tissue is normal, a big mediastinal shadow. Possibly, this is what is called saluting the heart. You can see the heart shadow. Again, this here you can see there is some big thing which is slightly pushing, but trachea is not pushed. Yeah, homogeneous mass occupying the left mid zone, lower zone. We will see what it is. The CT and angles are normal. It is likely to be pneumonia because collapse no push. We should not be. So this is likely to be a pneumonia because it is relatively homogeneous. Here again, I'm seeing this. All these things are normal. This is normal. That's normal. Bones are normal, everything is normal, but small miliary shadows you can see here on both sides, predominantly in the lower zone and also in the mid zone. What it says? Yes, if this is associated, here you can see the LA is dilated, LB slightly dilated, LB looks normal. You can see this. This is a pulmonary congestion sign. This is inverse mustache sign. LA is dilated, LV comes down like this. LV is not dilated. There is a mild dilatation of the adult respiratory distress syndrome. Yes, where rotation is normal, the case in the midline, good exposure, inspiratory film or slightly supine film. Yes, bilateral shadows. Now, if you go on to see only the ARDS, yes, you are likely to miss this, like carrots. To read an X-ray, go systematic, whether PA or A, rotation or not, penetration is fine or not, respiration, inspiration is down, not. Sixth, anterior rib is the giant inspiration. Soft tissues are fine. If there is an emphysema, if there is a hematoma, bones are fine. There is no fracture rips. There is no any scapular disease or anything. CT, cardiac, and costophrenic schematic.
So there is a chat box question. How to detect Kirli B lines? Arthur, can unmute yourself. Yes,
hello.
Parth.
All these lines are now easy to find out with ultrasound. So that is the only thing. What we see very difficult to see these lines. Only the minor fissure la konjam mild or edema mari or thickening. Hello?
So you mean to say it is difficult to find, only a minor fissure can be seen?
Yeah, the minor fissure is easily seen. There is, if it is going to be edematous, then yes, we see that the Kirli B lines are slightly prominent. Like we can see very well in the ultrasound.
Okay, but so he has answered in the chat box because his audio is not clear. You can go through the answer in the chat box also. If the audio is not clear, we will conclude this meeting. I thank our speaker, SARVA VINOTHINI Madam and Parthasarathhy Sir for a wonderful lecture for today's edition of online anesthesia. Next week, we are going to have a exam topic, that is anesthesia workstation by Dr. Sanis and breathing circuit by Dr. Gurudat. We will meet next week. Thank you. Thank you, Ananda. Sign off from you. Thank you. We can conclude the session. Thank you.